the New Jersey Center for Tourette Syndrome and Associated Disorders, NJCTS. Its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site, nor do we endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thank you, Kelly, and good evening, everyone. Before I introduce tonight's presenter, I'd like to call your attention to some events that have a pending registration deadline of May 1st. Teacher of the Year and Medical Professional of the Year. This is your opportunity to recognize your child's teacher and or doctor if you feel that they have made a difference in the life of your child living with TS. Additionally, until May 1st, we are accepting scholarship applications from graduating New Jersey seniors who are continuing their education in either 2- or 4-year college programs. May 15th is the deadline for our 11th annual family retreat, described as the best weekend of the year. And last but not least, join us on June 4th at Rutgers University to kick off our year-long TS awareness program. World Cup soccer goalie for the U.S. team, Tim Howard, will be there to speak about soccer, the World Cup, and living with Tourette syndrome. Registration for that is, information for that and registration is on our website. Now, without further delay, I'd like to introduce tonight's speaker, Dr. Lawrence Brown. Dr. Brown's presentation tonight is the first of 2 webinars on medical transition. The second part will be held in the fall and will go into more detail about the physician's responsibility at different ages and how they can help teens to become increasingly responsible for their medical condition and to make the choices that will best lead to full adult independence. Vignettes will provide real examples of the challenges of adolescents with Tourette and how a planned approach can lead to adult success. So we'll be advertising that as we get closer to it, but it's a great pairing with this presentation tonight. Dr. Brown is Associate Professor of Neurology and Pediatrics at the Children's Hospital of Philadelphia and the University of Pennsylvania School of Medicine. He is Director of the Pediatric Neuropsychiatry Program, a multidisciplinary clinic for children whose complex learning and behavioral issues have a neurobiological basis. This population includes Tourette syndrome, high-functioning autism, and complex ADHD with comorbidities. Also includes epilepsy, genetic syndromes, and other neurological disorders. Additionally, he is a senior clinician in CHOP's Pediatric Regional Epilepsy Program, where he is principal investigator on numerous clinical drug trials in pediatric epilepsy. Dr. Brown, welcome. And now, without further introduction, I'll turn tonight's program over to you.
Thank you very much, Marty, and I hope you can see my presentation. I'm actually seeing something covering part of the slide, but I hope that the rest of the audience isn't.
If that icon is in your way, click the orange button that has the arrow and it'll disappear for you.
Thank you so much, Kelly. Well, it's a pleasure to be back talking to my favorite Tourette syndrome group. Please don't tell my colleagues in Pennsylvania because I think that Jersey has the best Tourette support program in the whole country, and I've always applauded what they do. Tonight, I'd like to talk about a project that I've been working on for the last number of years, and as you'll see, it's both local and national, but I've been thinking about what we haven't been doing, what we ought to be doing, what we can be doing, as you heard earlier, to help people to achieve their full potential. And before I do that, if I can, page down, it doesn't want to go down. How do I do this? Before I do that, I'd just like to go over a few issues that try to put Tourette syndrome into context and to explain in part why it's so difficult and what we ought to be thinking about is so that we can improve the situation. Let's talk just for a little to make sure that we're all on the same page. I assume everybody here knows what Tourette syndrome is, but I'd just like to point out that the definition of Tourette has been very slightly improved, and I think really for the better, where Tourette syndrome means multiple motor and at least one verbal mannerism at some point in the course of an individual's life, and it has to be there for at least 1 year. There's nothing magic about it, and in fact we will often treat people who have severe problems less than a year, and I certainly only treat those who have problems in need of treatment, because many people don't have need if it's more than a year. In the past, you could not be free of tics for 3 months and have Tourette syndrome, but now that's been taken away. It's a childhood onset disorder. It's a developmental difference. And anybody that has seen many patients with tics and Tourette's know that it's most common in early childhood, and it becomes increasingly unusual to start in adolescence. And the older the child is, the more one has to think of an alternative explanation than the typical complex genetic disorder that Tourette syndrome is. It used to be that in order to have TS, the tics that the individual had to cause distress and functional impairment in at least school or home or work. That's also been taken away because there's no way to distinguish a person with severe tics who does well with them versus a person with very mild tics who has problems managing. And it remains true that it can't be caused directly by putting substances into the brain, such as drugs, street drugs. Stimulants I find challenging because most of the time the stimulants have been there earlier and they never caused a problem, and then when the child is older you start seeing tics, and it's not clear that it's causing it, but in fact the definition by the committee suggests that if it's produced by stimulants, then you shouldn't call it Tourette syndrome. In practical terms, I say that if the child has never had tics and has tics within 2 weeks of starting a stimulant, you can call it stimulant-induced Otherwise, it's just an exacerbation of a previously existing condition. So how common is Tourette syndrome? It's been estimated between 1 in 1,000 and 1 in 100. And that tells you that it's particularly difficult to figure it out. But I believe that the smaller number, which is still hundreds of thousands of children across America, the 1 in 1,000 are the children who used to be identified with impairment, and the 1 in 100 are the ones with who include those who don't have particular disability due to their tics. We also know that it's 2 to 4 times more common in boys. And what we know from our colleague Dr. Curlin in New Jersey when he was in Rochester was if you send out research associates to sit in elementary school classes from kindergarten to 6th grade, tics are seen, at least one tic in the course of 1 year, in 1 out of 4 to 1 out of 5 children. More common in those with other special needs, but still, without any other factor, 1 out of every 5 children. We also know about Tourette syndrome that between 50 and 60% have coexisting ADHD, and that typically starts several years before the first tic. So on average, it's 4 to 5. The first manifestations of the tic disorder are almost always motor, and they're always or mostly simple, and that's followed by the verbal mannerisms and the OCD. Most tics involve head and neck. Cephalo means head, and caudal means bottom, and it tends to move downward over time, and it tends to become from simple or just eye blinking or head turning to more complex, which can be confused with meaningful motor activity or full words. What we've begun to be more aware of is that there are parts of the brain that are critical in the ability of a child to induce tics and in the ability of the older child to outgrow tics. And it's the maturation of that part called the basal ganglia, which are collections of neurons deep within the brain, which appear to explain the tendency as they mature with these wheels within wheels that control our ability to have smooth and meaningful movement for the tics to go away, particularly about the time in association with puberty. So if one looks back or ahead, that in the individual, on average, and remember, not everybody follows average, but on average, tics tend to be at their worst in the prepubertal age 10 to 11 and tend to improve or disappear entirely by mid-puberty by 16. And lastly, what I want to remind everybody is that even the latest DSM, or Diagnostic and Statistical Manual, 5th edition definition of Tourette is only describing the tics and does not include all the other, sometimes much more significant, other disorders that make Tourette so challenging. If you put it all together, as I said, ADHD is often seen first, and then simple tics, the rituals, the more complex tics, the verbal mannerisms, and by late adolescence, the improvement. Here it is in a slightly different way of seeing it, where ADHD starts showing up early, tics later, and OCD even later. I would point out that blip early in the preschool children because it is absolutely normal for children to be ritualistic, repetitive, want to hear the same story over again, want to do the same thing time after time, and that is age appropriate and not a signal that they are having or will develop significant OCD at any point. ADHD is seen in about 2/3 of individuals with Tourette syndrome, OCD in about 1/4, but repetitive ritualistic behaviors that don't meet the psychiatrist's definition are even much more. And talking to an audience of people who care about Tourette syndrome, you know that it's even beyond that. Anxiety disorders, intellectual challenges, and learning disabilities. I would point out that autism, even in its current recognition, where it's much more than 1 in 100, maybe approximately 1 in 60, according to the latest CDC numbers, it's still much more associated with tics, but not identical as tics. Yes, autistic children have stereotypic behavior, but the flapping is not confused with tics. And we think that it's the same parts of the brain that are not functioning as expected in autism that overlap with the parts of the brain that are developmentally different in children with tic disorders without autism. But it doesn't mean that if you have tics, you're autistic, and I think everybody recognizes that. And the last thing I'll say about the comorbidities is that it's hard to have tics, especially if you have ADHD and OCD. You have a disorder that makes you want to do things and the disorder that makes you want to be in control, and you're out of sync with yourself so that you can be frustrated, aggressive, and rage attacks are almost universal at some point, particularly in the early and mid-adolescent period before the hormones settle down. Why do I emphasize these different disabilities and comorbidities? Because as I said earlier, tics define Tourette syndrome, but the disabling features are often not the tics and are often more long-lasting. In a very big survey, international survey by the Tourette Syndrome Consortium, only 12% of the people who responded had only tics, and over 80%, almost 90%, had other additional problems. And as I started to indicate, tics are frequently outgrown, but if you have ADHD, if you have OCD, if you have anxiety disorder, they tend to have a life of their own and may not be outgrown as quickly. So with ADHD, again, I just want to remind people with my favorite cartoons that we can have the hyperactive impulsive type on the left with Dennis the Menace saying, by the time I think about what I'm going to do, I already did it. Or the other type, the inattentive type, where the gentleman is saying, excuse me, doc, my attention wandered. What kind of deficit disorder did you say I had? And I like the right side in particular because we're looking at an adult. And interestingly, ADHD was the only medical disorder that I'm aware of for which treatment until recently was only available for children according to the FDA, and there was no treatment for adult ADHD because, in the opinion of people in the past, ADHD didn't exist. Well, we've learned that lesson, and it's a very important issue that we shouldn't forget. We can treat ADHD when it's important in Tourette syndrome. And I should point out that when I treat, I always try to target the most disabling problem because not all problems need to be treated, not all flags need to be saluted. It always is a multifactorial approach. It always starts with behavioral approaches, family approaches, educational approaches. For mild to moderate tics, I would like to suggest that almost all algorithms begin with the adrenergic drugs, which are guanfacine, also known as 10X or Intuniv, and clonidine, also known as Catapress or Capve. If the ADHD is the most important aspect and the tics are mild, atomoxetine or Strattera is not a bad choice. I am not saying you shouldn't use stimulants. I am not saying that stimulants cause Tourette syndrome, but I am saying that stimulants do have the possibility of bringing out tics, and stimulants also have the possibility of making anxieties worse or picking behaviors worse. We do have wonderful variations of stimulants from methylphenidate and its variant dexmethylphenidate, also known as everything from Ritalin to Focalin, and the others are based on amphetamine known as Adderall or Vyvanse. One can have a 4-hour version, a 6-hour version, a 12-hour version. The one thing you can't have is a 24-hour version, and that's another reason why the adrenergics and this atomoxetine may be advantageous, because life is a 24/7 proposition and not only during school hours. It is possible off-label to use other medications, but those are becoming increasingly rare as long as we have better and safer options. I put down the combination of stimulants, which are the most likely to be effective, along with a powerful drug such as risperidone or Risperdal or aripiprazole, Abilify, with a stimulant as a last resort, because I believe that nobody should be treated with something that causes a problem which requires yet another treatment if it could be avoided. Why do I emphasize it? It turns out that ADHD and Tourette syndrome often go together, And it's the ADHD which is most associated with problems. And I put here many of the problems starting early and all the way into adulthood that can impact an individual's emerging independence and self-awareness and ability to carry out life, beginning all the way from low self-esteem in childhood, and don't forget the risk-taking leading to injuries, to academic problems and difficulty with family relationships and friendships, to self-medication to make oneself feel better, with smoking and marijuana in particular, that can help a child to relax and calm down, but have risks of their own. And then in adulthood, with failure to be able to finish college or maintain a job, and risk-taking that leads to problems where they get targeted because they were not careful. OCD is common, and my favorite cartoon on the left, I will stop my OCD, I will stop my OCD, I will stop my OCD, and the boy is saying it just doesn't get any better than this. Somewhat differently, I would emphasize the non-pharmacologic approach, even though I did say that family and behavior is important with ADHD. What we know is that cognitive therapy is as important as medication. One thing I've learned recently is that treating complex kids with Tourette syndrome and OCD, often the behavioral therapist tells me that they have a hard time getting through to the kids unless they're on medication and the severity of their OCD is tamped down somewhat. We do start with serotonin reuptake inhibitors, and the ones that are oldest and most understood in children and approved include fluoxetine or Prozac and sertraline or Zoloft. Studies have been done, and I know that there will be a seminar coming up with Dr. Franklin, and Marty Franklin at Cottage did some wonderful work proving that the combination of cognitive therapy and an SSRI actually was superior and required less medication. There are other treatments as well. And when we're talking about OCD and also tics, I want to remind people that it is cognitive therapy, and it's based upon, at least for the tic part, the fact that older children begin to be aware that their tics are often preceded by the feeling of having to do it and having to get it right. And it's that premonitory urge that gives the psychologist the chance, even if it's a split second, to change and for them to, for the individual to be in control by use of the techniques that have been developed by Dr. Franklin, Dr. Doug Wood, and others. There are strategies that you need a team approach. It's not just a neurologist. It's not just a psychiatrist. But you need the psychological support, the educational support, and understanding family, and a few friends who stand behind you. the medical teams need to be able to communicate. They don't have to sit in the same room, but they need to communicate. And as we segue into the transition, it becomes increasingly important to involve the individual in the treatment plan. Any child who doesn't understand and doesn't participate and doesn't own his own problem is not going to successfully transition as well. And certainly, and we've been discussing this at various venues, when does that begin to happen? I think people now understand, based upon the science of the developing nervous system, that as early as 12, and certainly by 16, the child, the adolescent, is capable, if they have normal cognitive ability, should be capable to be part of the story. And I'm as guilty as anybody, and hopefully less so in recent years, of talking to families as if the child were still an infant. But I think that it's really important for people to advocate, that's both the parents as well as the child, to advocate for time to be addressed directly, even without the parents in the room, so that they can ask questions and get answers. Finally, I'd like to say that it's important to maintain optimism, because we don't want to have a self-fulfilling prophecy. If you don't try, you may not get there. If you do try, you may not get there, but you have a much better chance. Tics tend to go away. They tend to have bad times, but they also have good times. And you could remember those even when it's hard. Let's talk about transition. That's what we're supposed to be doing. And it's a process that begins in childhood. It prepares people. It's not one moment of time. It's a process. And most people, even some of my colleagues, think about transition as the transfer when you turn over the care to an adult practitioner. That is the final stop, but that's not the story. So you have to know that we're in this with you, and as a neurologist, as a pediatrician, that when you have a child with Tourette syndrome, it could seem like an endless tunnel, but there's always light at the end of the tunnel. I can't tell you it's going to happen tomorrow, and I can't tell you it's going to happen when it's 15, 16, or 18, but yes, the hormones settle down. Yes, the brain, the frontal lobes finish their maturation, and yes, kids grow up. We have a hard time, and I'm not sure if these are the only reasons why, but you have to know that you bond with your doctor, and the doctor has bonded with the child and bonded with the family, sometimes over 10, 15, or more years. And we also know, because we're patients ourselves, that the culture of pediatric care, I like to say that people who practice with children are special because they're paternalistic in the best sense of the word. They care about their patients and their families, the context within their community, and that's different from the very individual-based care of an adult practice. And we tend to see the adult care as somewhat narrow and perhaps overly focused, but it's different. And then the pediatric specialists have learned to love our patients, but we can't always find equal adult practitioners who like such complex, behaviorally challenged, often intellectually disabled patients who can be disruptive and negative at times and may not always have the best insurance. Now, not all in transition is bad. I started at the Children's Hospital of Philadelphia in 1971 at this place, this one building on Bainbridge Street. And there was a transition in 1975 to this. And CHOP has become a major institution. And those of you who've been in Philadelphia recently have seen this new, unbelievable building where I'm really thrilled to say that in the same neighborhood, on the same floor, we will have psychiatry, neurology, and developmental pediatrics, as well as psychology, so that we will finally be able to communicate and work together in an even more meaningful way on an everyday basis. So transition is a fact of life. It shouldn't be, like the picture shows, sending somebody off a cliff. Instead, we have to really worry in advance and think thoughtfully about how to prepare these teenagers and young adults how to take responsibility for managing their medical issue and how to be completely independent as much as they're capable. And that means taking responsibility for their education, for their work, for their social relationships, and finding the people that we know and trust will be able to carry out the legacy that we hope we've done well with our patient. It's really been happening over the last few years. I'm not the only one talking about it. This is from the state on the left. It's from a partnership between Children's Hospital and Penn on the right. It's really happening. We even have some well-established questionnaires and surveys that raise questions, and whenever I give it to people now, it's amazing how teenagers sometimes will look at you. They can drive the car, but they don't know how to refill their prescription. They don't know how to make an appointment. They don't know what insurance they have. And these are things that have been validated nationally that show how a child, what an individual needs to do to become adult in the medical patient sense. So what are some of the issues that can be affected? I think that people need to increasingly take personal responsibility. I've said that before. They need to become independent. They need to know who they are. They need to feel good within their body. And does Tourette syndrome affect these? You can bet your life it does. If it's personal responsibility, kids will ask me over and over, why do I have to take the medicine? I'm the only one, it seems. They want to be like everybody else, and they say, I'm not supposed to do the things my friends are able to do. You tell me that I'm taking medication, I can't even have a beer. I certainly am not supposed to do other things that everybody else seems to be doing. They don't want to take the medicine because many of the medicines, particularly the neuroleptics, the Abilifys and Risperidals, can cause increased weight. And personal identity, they don't feel good about themselves, and they have trouble making connections and friends and more intimate relations. So we all have to think about these things, and I bet that many of you, even those who've been my patients, have not always heard us talking about these things, but more and more we are being sensitized and trying to do the right thing. So transition really needs to start early. It needs to start in high school. The special education indications say the same thing, that as early as 12 and no later than 16, that you need to be preparing for post-high school, and we think that medically we should be doing the same thing to make sure that a child, the way I like to put it, is that we are opening as many doors as we can in front and closing as few as we can behind, so that I don't care if a child goes to technical school or graduate school, as long as they're doing what they want to do and what they're capable of doing, and not what's left because they've messed up and can only do certain things. We want families to be aware of what the resources are that the doctor's office can't provide, and we also want them to know that it may not be we may not be able to do as much, that if you're in special ed, for example, everything stops at 21. And we can't easily continue, even if it seems worthwhile, to be able to get the occupational or physical therapy, to get the in-home behavioral services, etc. So we need to prepare. I've already said over and over that the tics are often outgrown, but the other problems, the ADHD, the OCD, the anxieties, may not be outgrown. I once asked the family about family history, and the mom said to the husband, "What about your brother?" And it turned out that he had outgrown his Tourette syndrome, but had never left the house in the last 5 years because of the disabling OCD. And the other thing that I want to be honest with people, because I've seen it more and more if I stay in touch with adult former patients, is that there may be, even if they do well, when the economy went south in 2008, I had a number of patients whose residual ADHD was a problem. They had done well enough, but they were the last hired, they were the first fired. They had a hard time keeping it together. We also see that even if they outgrow some of the issues, then they go off to a college and live on their own. And as I joke with the kids, unless you want to take your parents with you and stick them in the trundle bed under you, you're going to have to start being in charge of waking up yourself, in charge of planning your day yourself, in charge of taking your medicine yourself, in charge of organizing your life. And that can be very hard. And there are all sorts of risks of independence. Parents have been asked, and they've told us that the reasons they don't want to move on is because they just don't want to move on. They often think that adults don't understand the problem. They may understand the problem, but there aren't enough and they can't find them. And they don't want to go into a form of fragmentation where they have to see a psychiatrist for the neuroleptics and a neurologist for something else and a psychologist for something else. And then one of the problems is that medicine has become so difficult it's hard to find the time to do it all. We often don't know about the community resources. People become shocked when they haven't been told about the difference in the adult culture, when they face it and they want to bounce back. Sometimes kids move on, but the patient's unready, not ready to take responsibility. And this is not Tourette syndrome, but in something like renal transplant, it turns out that when somebody graduates to adult care, there's a very high risk that they drop out and never see the doctor. There's an incredibly high risk that their kidney transplant will fail in the first 2 years when they move on. So that there is this whole change that could be, you think it's one step forward, but it can also be 2 steps backward. And then some of the other issues, if you have a child with intellectual disability or physical disability, the changes in the way we provide care and fund it and how we can get around now that the parents are older, the kid is responsible and trying to take public transportation can be really difficult. And also, it's hard to find the resources to pay for things. What can we do to make it better? We can develop a plan. It turns out that in many cases in medicine, a plan, any plan, is better than winging it and making it up as you go along. And we don't want to do that anymore. And we also want to help the child avoid dropping out when he becomes a young adult, as if we increasingly make him more mature and make him more self-responsible. It's getting late, and so I'm going to race through a couple of slides, but I've been at this for a while. I'm actually running a national transition initiative under the Child Neurology Foundation that I was president of in the past, and hopefully within the next few months the principles of transition with special attention to child neurology will be published. To tell you some of the things that we're doing here, we're developing a program. Children's Hospital is very active throughout the hospital, and in neurology we're trying to get people to have done this for years and then to make sure that when we transfer the patient at the final step, that the receiving doctor has full information so that we be comfortable that they understand where the child, now adult, has come from, and that they can deal with the issues that are left. We have programs that are based throughout the hospital at various ages, beginning in early adolescence and changing all the way through adulthood, and programs to help kids to discuss and families to discuss the emerging independence, the self-care, how to advocate for yourself, how to deal with relationships, the same sort of thing that the kids at Camp Bernie are discussing, and I recommend that highly. May 1st is coming up. And behind the scenes, there is a transition special interest group where every month from all over the hospital we meet, and we've been working particularly with the electronic medical record to encourage parents to mostly to encourage doctors, but now that there is a special portal for patients to encourage patients to advocate and to tell them what to expect from their doctors if their doctors aren't doing it. And so there was just announced last week a new initiative that will be trying to push this even further to basically empower the patients and the families to do a better job with transition and prod us, the physicians. In the Division of Neurology, we already have put together organized plans for various aspects of neurology, but with Tourette syndrome, we now have an adult neurologist who can not only see the children, but even see the parents if they have questions about themselves right at our facility. And we've also been partnering with Dr. Tony Rostein and the Adult Developmental Disabilities Program, which is psychiatric and psychologically based. In summary, I would say the transition is really gratifying, starting with a young child who develops his own interests, and in this particular very artistic child who went into claymation and had a little bit of a sideways there with the long hair. But when you get it right, he's now a filmmaker and doing documentaries and on his own. And so I just summarize everything by saying that it seems as though growing up in transition is impossible, like jumping a fish out of water, but it is necessary, and all patients really deserve to graduate. And you don't have to tell your kids that checkout time is 18 or 21, but we have to remember that the goal is to be successfully transitioned and not just transferred from one doctor to another. And so I just like to thank everybody and all the patients that I've worked with for many years and the ones I'm still working with to hope that they all grow to their full potential. And with that, I'll stop.
Okay, thank you. Great presentation. And we have quite a number of questions, so I'm going to launch right into them. Can you elaborate on potentially the increased incidence of motor vehicle accidents, either from your experience or in the literature, with children with, or teenagers, I'm saying in this case, with TS? I imagine it's not spelled out clearly.
So the increased incidence of accidents is purely driven, in my opinion, by the ADHD. That I've never heard of a child who had an accident because he had a tic while driving and tossed his head and lost track of where he was. It's the distraction, it's the way that people with ADHD hyper-focus so that they really compensate by looking straight ahead, but when they do that, they miss what's happening on the side, and the crazy driver who jumps into the lane causes them to have a problem. Or they just have to answer the cell phone, and they just can't not. So I really do believe that the tics are not the driver here. I'm sorry, I shouldn't use that term. The tics are not the cause of the problem. It's the comorbidity.
Uh-huh. Okay. How do you encourage a child with TS to be more independent? It seems that the more control over her life that that this parent gives her daughter, who by the way is 17, the less that she does. She refuses to do things. So how do you motivate the kid to be willing to step up to that?
That is a wonderful question, and I'm sure that there are many parents who can answer this better than me, who've been through it. I think one has to individualize and find out how to make a child feel good about themselves, how to help a child to be in control with the things that are difficult for them, so that they're not despairing and not angry all the time. And little by little, and this has to start earlier, to transfer responsibility to them. And that's why I think that cognitive therapy is so helpful. It turns out that even if it doesn't reduce the tics on an objective basis, it usually does, by the way, but even if when it doesn't, more often than not, kids feel good because they feel like they're in more control. I don't have a really excellent answer for that wonderful question, but it is what keeps adolescent psychologists, social workers, and psychiatrists going. And as a neurologist, I do the best I can to support people.
Mm-hmm. It's maybe a little bit like the chicken and the egg too, because you give the child the lead, and they choose not to lead. I mean, it's almost, could it be just a conscious decision they make not to lead and not to take that initiative? That's their choice.
When that happens, that's dysfunctional. And what I think parents need to do is not to get angry themselves, but to figure out how to challenge, to realize that this is not in their best interest, that they're just harming themselves and they're limiting their own successes and potential by turning it into somebody else's problem. I'm going to show you, and so I'm not going to do it. I'm going to. But I'm not trying to be a psychologist. Lord knows, all I want to do is to be a good neurologist, and I'll find the psychologist for you to help you.
Okay. There's a question that, in my experience with the Tourette organization, I have seen come up a few times, and it has to do with this particular child is 9, and the mom says that we never really have gone much into depth about his TS. We thought that we were protecting him. Now I think we've made a mistake, and how do we begin to clarify things with him in light of this presentation that you've done and having kids step up and kind of own it? When you protect the child, that gets kind of hard to do if you wait too long.
Well, it certainly doesn't make it the easiest, but it doesn't make it impossible. I don't want to sound like a Hallmark card, but today is the first day of the rest of your life, and a 9-year-old is certainly not too old to begin to open up. I actually find it difficult when parents come to me for the first time and they ask to leave the child outside so that they can talk about him as if he doesn't know anything or she doesn't know anything. And I say, I'll do it any way you want, but remember who the person is who has the problem. They have to live with it too. And I think most people, if they really are honest, and if they have any memory of their own childhood, know full well that the kid knows far more about what you're hiding from them than you would like. That they know if there are conflicts between husband and wife. They know if there are financial issues. They know if there's an impending move or somebody's sick. And whispering about it only makes it scarier and makes it more challenging. I think you just have to open up and realize that the kids are not going to fall apart. And I think that I don't know at what point, but certainly by pre-adolescence, by 9 or 10, a child knows what a tic is and needs to have some explanation to tell his friends, and may need to ask, and I just saw it in the office yesterday, about the child actually asked the mother to get the state Tourette Syndrome Association to come in to talk to the class because he didn't know what to say. And that was in 3rd grade. And that's the way it should be.
Okay, thank you. I have someone asking who the adult neurologist at Penn is. Is that something you could
That's no problem. He's been around for a long time. It's Dr. Michael Rubenstein.
Yes, we know him.
Who came to full-time at the university 2 years ago, and the first year he was there, he won the Best Teacher of the Year award from the residents. So he's a wonderful resource that we really appreciate having.
That's great. Okay, thank you. Do you find that kids with Tourette seem to mature a little bit later than the average? And do you think that would factor into their ability to kind of own this whole transition thing? Do you think it might happen a little bit later for them than it might for the...
Great question. And because I've seen so many kids with all colors of the rainbow, I would submit to you that you've just asked again something that reflects more about the ADHD than the tic problem. By that I mean, on average, kids with ADHD are 1 to 2 years developmentally behind in many ways. When I see a kid who only has tics, I don't see that. Okay? Again, I believe that it's a difference in the in the way the brain functions when there's also ADHD. I'm not saying it's because of the ADHD. I think it's the brain difference that produces both the tics and the ADHD. But it's the ADHD which, even without the tics, you see, and you don't see it with only the tics.
Do you find that with OCD as well, or just the ADHD?
I think it's mostly the ADHD. The OCD has many more emotional challenges, and all of this can be confused with the medications and the failures of comprehensive approach sometimes that we unfortunately deal with. We can't always get it right for everybody, as you know. But I really do think, and I'm not trying to demonize ADHD, but I really do think that in part because it's more prevalent, and in part because of the pathophysiology that it is what causes more of the problems and more of the delays.
Mm-hmm.
I can't prove it, by the way.
Okay, but it's a good theory, though. Do you see any difference between boys and girls in their willingness to involve themselves more in their treatment? Does that stack up anyway?
Oh, that's a good one too. I have seen 6-, 7-year-old boys who have tremendous insight and 17-year-old girls who don't know what you're talking about. I think if I have to be simplistic, I do think that girls tend to be more aware and willing to be open to the advantages of the work that has to be done if you're going to be, and motivation that has to be there if you're going to participate in habit reversal therapy or the other forms of CBT that help anxiety and OCD.
Okay. I have a question from an educator, actually, asking how you see that educators might get more involved in helping the child in this transition.
Well, I think that at least I am at the very beginning of this. Dr. Franklin and I have a meeting coming up with a intermediate unit in order to try to develop a program in how educators can do a better job specifically for Tourette syndrome. I'm not going to tell you where it is because it hasn't been finalized, but we're hoping to do that in a way that makes sense and helps the educators who I know are committed to this whole process of bringing out the best in kids, but who don't know. And one of the things that we may do is try to help school psychologists in order to learn how to do cognitive therapy. But I think that there are lots of other ways that schools can support children with Tourette syndrome so they're not marginalized and felt to be less worthy because of their challenges.
Okay. Do you think it's odd that the new DSM does not include the comorbidities, particularly OCD and ADHD? That seems inconsistent with the study you mentioned and those numbers.
Yes. So I think that it is a dance between clinical practice and science. And sometimes the clinical practice drives the science, and sometimes it's the other way around. I would expect that if some of the advances that I foresee hoping will be here in the next few years demonstrate the identity, the close relationship within brain mechanisms and genetic predisposition, that we will eventually have something that is not symptom-based only, but more biologically driven, and will then collapse things in a different way than we do now. I probably didn't say that as clearly as I could have, but in other words, what I mean to say is that when we understand, based upon the new insights in the human genome and the chemical and other biological processes that lead to tics, that lead to OCD, that lead to ADHD, and we can tell how they're related, we'll have a new set of definitions that are based on that, which is much better than basing it on just pure symptoms alone.
Okay, thank you for clarifying that. I think we have time for one more question. Well, actually, it's kind of a double question. So, is any part of this transition that you've discussed today, this initiative, being covered anywhere along the line in medical training, or is this all, this all occurs afterwards?
To the best of my knowledge, medical transition is not yet covered specifically in any medical school. This is something that I think is being driven in part by the advances in medical science. A generation ago, if you had cystic fibrosis, you weren't expected to live beyond 20, and now the average age is 45. Similarly, sickle cell disease, chronic renal disease, rheumatoid arthritis, etc. We are congenital heart disease, and neurologic issues are really doing the same thing with some of the most serious disorders that were fatal before we had good transplants and new advances in medicine. Unfortunately, there's so much to cover in medical school that this is not yet part of the most important things that most people believe, and part of what I've been advocating for and what I'm trying to do in some of my other work is to demonstrate how important it is, how it improves people's life, how it even saves money, and we do a better job, but it's going to take time for it to filter into education.
All right, well, we've gone over quite a bit, so I think we'll wrap it up there. The other piece of that question, I'll make sure it gets on the blog. So with that, I'm going to close the Q&A portion and pass you back to Kelly for a final wrap-up. Thank you.
Thank you all for joining our webinar on Outgrowing the Child Neurologist, Medical Transition in Tourette Syndrome. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted on the site. Our next presentation, OCD and teens or young adults, how to keep them engaged in their own treatment, symptoms, and lives, will be presented by Dr. Martin Franklin and is scheduled for May 6, 2015. This ends tonight's webinar. Thank you, Dr. Brown, for your presentation, and thank you everyone for attending.